then in response to an RFA from the National Institute on Aging to design a study that would focus on the causes and consequences of disability trends and also allow investigation of disability dynamics and individual pathways to disability in the older population. The data collection for the study began in 2011. It's meant to be a new platform for the scientific community at large. This is not a study that's been designed solely for the use of the investigative team. It's nationally representative of people 65 and older and has been developed with broad input from the scientific community, people from lots of different disciplinary backgrounds and training. And a key objective is to disseminate the data, get it in the hands of those of you who are trying to understand the aging population today and move us forward in that area. This shows you the team that's currently in place. I'm the principal investigator. As was mentioned earlier, Vicki Friedman at University of Michigan is a co-PI. We have a great team of co-investigators who bring a lot of different expertise, geriatrics, epidemiology, health economics, demography, health services research to this study and its development. We spent about 2 years in the initial phase working through and developing our conceptual framework and the study content and design and approach. We also have a scientific advisory panel of external investigators whom we meet with regularly and allow us to bring additional expertise into the picture. Some of you may know Jack Goralnik. He's been someone who's done aging research for many years, who's on our panel, and I could list the others. But so it really has been a study that we have tried to develop that will represent the ability to provide data to researchers across a very broad spectrum of research. So I want to spend a little time going over our conceptual framework and how we have measured key components of this framework, because those really are central to the data that we've produced, and then share some results with you that highlight, I hope, the possibilities of the approach that we've taken. So these are key concept areas, very big picture in terms of NHATS, and the green boxes you see here all fall under our disability umbrella or disability rubric. I want to draw attention to the boxes that are outlined in the middle and the dotted line. This represents important work that Alan Jetty and Lois Rabruga did in terms of laying out the disablement process. They describe disability development as progressing from disease to impairment at the level of the person, for example, in discrete functions such as walking or bending or reaching, to limitations in ability to do complex activities and tasks. And this has been an important foundation for much research on disability in both the older and younger populations, particularly work that is focused on that transition or that relationship between the impairment box in the middle and the activities on the end. There are two important conceptual additions in this framework, and those are to explicitly recognize environment, which you see up at the top, and then compensatory strategies or accommodations, which you see down at the bottom. So if we focus in more closely on the disability conceptual part of that framework. There were other boxes that you saw there which represent other important content areas of NHATS, but I'm not going to have time to talk about those in much detail today. So a few things to point out here. We have sort of separated out or further disentangled the impairments from what we call capacity. This represents, in our view, sort of underlying building blocks for activities. In the physical realm, that would be something like walking, and in the cognitive realm, that would be people's cognitive functioning abilities. And we think there are advantages to that, as well as I mentioned bringing in the environment and accommodations components in being able to look at some relationships that we have not previously been able to investigate as thoroughly. For example, how changes in capacity affect someone's ability to, or lead to accommodation, or perhaps not, and then how that goes on to affect the activities. And lastly, I would point out that in the box at the bottom, which has self-care and domestic activities, or IEDLs, that's another term that has been used for household activities, sort of the kinds of things that people need to be able to do, meal preparation and so on, to remain functioning independently in the community. We have added participation in productive or valued activities as another important outcome that really reflects activities that people care about, contribute to their quality of life, and go beyond just our being concerned about basic self-care and community maintenance kinds of activities. And so we have incorporated that concept. It's something that is part of the International Classification of Functioning. Alan has written about the need to pay attention to that and thinking about disability, and we also have operationalized it, and I think this is a unique feature of NHATS that is not in any other current studies. So let me now turn to the measurement side of things and kind of walk you through some of the ways in which we've taken these concepts and operationalized them in the interview we do with older people. So environment actually touches on several different domains. We measure people's social environments in terms of family, social network, whether they have people to talk to about important things in their lives. We have a lot of information on the physical environment, features of people's homes, modifications people have made to their homes, and some items that give us information about the interior and exterior condition of people's homes. In the technology area, we're interested in who's going online and who's using, that kind of technology to do activities like banking, and also for social communication purposes. And then finally, because NHATS collects a fair amount of information to help us understand what kind of residential environment people are in, not only traditional community, but also supportive residential care settings and retirement communities. When people are living in those kinds of environments, we collect information about the services that are available in those environments, because obviously one sort of accommodation that people may make to deal with functional change is to relocate into environments where services will be available. Measures of health conditions and impairments are fairly straightforward. We do have self-report of diseases, but we also are linking to Medicare data so that you have very detailed information about diagnoses for the population. If we look at the measures of capacity that I was talking about earlier, these building blocks. So in addition to some of the classic self-report kinds of questions about walking 3 blocks or reaching and so on, we do performance-based tests in the physical realm to try to standardize measures of underlying capacity, and then we also do some cognitive assessments. Turning to accommodations, these cover use of devices. These could be walkers. These can be home modification types of devices, grab bars, and so on. And we tailor the questions we ask to the activity where these devices might come into play. We ask about help from others extensively throughout the interview. So for each activity that we're asking people about, we ask whether they're getting help, and for the household activities where it's always been difficult from a measurement point of view to figure out whether someone is not doing the meals because they don't like to do the meals or they can't cook, and that's why the other person does the meals. We have an approach I'll go into a little more detail that helps sort that out when health and functioning is really at the root. And then finally, another kind of accommodation that people make, and this relates to some earlier work that Linda Freed did actually, in terms of recognizing that one of the things that happens for older people is that they, before they will report difficulty, they may simply reduce the level of activity or reduce the frequency of an activity as a means of trying to address underlying change. So as I mentioned, so now I'm going to just quickly go through those three sets of activities and give you a sense of how the information comes together around each of those. So with regard to mobility and self-care, we ask about whether devices or technology are involved, whether there's help from other people. If someone ever does the activity by themselves, some people always have help, but if you ever do it by yourself, is it difficult? The frequency item is asked, as I said, and then we also have questions around unmet need. So unmet need is a difficult area in terms of measurement, and we've taken an approach to try to get a handle on sort of concrete adverse consequences. So for people who are getting help or have difficulty, were they unable to go outside in the last month because the help wasn't there or it was too difficult? So not asking kind of global questions about do you need more help with X, Y, or Z, but to try to document specific consequences. This shows you the household activity approach, which is different and starts with trying to establish how these activities are done. So these are meal preparation, shopping for personal items, those kinds of things. So we first are interested in knowing whether the person always does it by themselves, whether somebody else is involved, it's a shared activity, or whether somebody else is doing it. And then if someone else is involved, we ask whether this is a health for health or functioning reasons or some other reason. So, the preference kind of issue that I was talking about earlier. And again, we get details on devices or other things that may be involved in doing the activity, difficulty, the frequency, and unmet needs around those. So finally, participation. So this is a set of questions. These are elective activities, socializing, attending religious services, and being involved in clubs, going out for enjoyment, caring for another person, working for pay, volunteering. And around each of these, we ask whether the activity is being done, whether their health, or for some of these, transportation, asked separately, are limiting their ability to do the activity. And then we ask, well, how important is this activity to you? So it's giving us a sense of the extent to which health and functioning may be interfering with people's abilities to engage in activities they care about. Another thing we do is we ask people at the end of this section to tell us a favorite activity they have. This is a verbatim kind of thing. So somebody could say, well, it could be something we've talked about. They could say, my favorite activity is playing bridge. They could say, my favorite activity is going to football games, and even if they like the Patriots, we would still take that particular answer. So it's a verbatim kind of response. And then at each interview, we follow up and say, well, when we talked to you a year ago, this was your favorite activity. Are you still doing that? Are you, is your health restricting you, and so on? So that covers the measurement portion. So before I share some results, I'll tell you a little bit about the sample design and data collection. So the study population is drawn from the Medicare enrollment file, beneficiaries 65 or older. Over 8,000 people were in the baseline at 2011. Estimates are that about 95% of people 65 and older in the U.S. are on the Medicare enrollment file, so it's a good sampling frame for this population. The design is age stratified across 5-year age groups, so we oversample in the older age groups so as to get good representation across the age spectrum, and we also oversample in Black individuals to enable people to look at racial disparities. NHATS involves doing annual in-person interviews. These are about 2 hours in length, and about 25 minutes of that is the performance activities, the physical performance activities I was talking to you about earlier. We're currently in the midst of doing round 5 data collection. And so we're replenishing the sample at this point. Dissemination is an important activity for NHATS. We have a website, nhats.org. You can go there. You will find data, the 4 rounds of data that have been completed, documentation, technical papers. We've tried to make that information available and accessible to the research community. As I mentioned before, there's a national caregiving study, which I won't be talking about much. That's also available on the same website. So I just wanted to show you one recent slide as we've been thinking about our annual data collection strategy. So we implemented that interval based on looking at other work that has gone before and concerns that, particularly at the older end of the age spectrum, changes can happen relatively quickly, and at longer intervals you will miss much of the picture that you're trying to put together. So we do have in the study for selected accommodations and mobility help is one of these, a continuous monthly record of what is happening. And so this shows you, just looking at a 2-year slice, the percent who report mobility help if you were asking at a 2-year interval, that's in blue, and then the percent that would report mobility help if you look at this monthly picture over the same 2-year interval. So it's not surprising, perhaps, that we are picking up more episodes of disability with this continuous measure. But the other thing that is kind of interesting about this is if you look at the younger age range, that's where you see a much bigger difference actually between these two approaches. So that's suggesting that at those younger ages, there are these episodes of mobility help that are happening kind of in between our annual data collection that we pick up with this continuous measure. So this is something we've just been digging into, and I think is interesting, again, from kind of a measurement point of view. So NHATS is able to provide information on levels of assistance as traditionally measured. This shows help from others and across all residential settings, so about 29% of the population 65 plus, or about 11 million people, are receiving help with self-care or mobility or household activities for health and functioning reasons. Under 3% of people are in nursing homes, and about 1 in 4 are in that what might be regarded as a severe disability group, receiving help with 3 or more activities. So another perspective that we can bring is the one regarding unmet needs. And this is another way to kind of think about perhaps the most vulnerable people in that older age group. So as I said, this is activity specific and focused on adverse consequences. So the least common type of adverse consequences is going without eating, at all. The most common are those that involve not being able to get around in your home or building, or having to stay inside and not being able to go outside, again, because either you didn't have help that you usually have, or because of difficulty. And in all, about 15% of the older population had at least one unmet need. So finally, now I want to turn to a spectrum of late life functioning that we can put together given the NHATS approach. So Healthy People 2020 has targeted a 10% reduction nationally in the proportion of older adults with moderate to severe limitations in daily functioning. But we think many of the common approaches to trying to monitor disability miss some important groups that we can identify, in this spectrum that I'm going to talk to you about. This comes from an article that was recently in the American Journal of Public Health by the NHATS team. Vicki Friedman was the lead author. So this spectrum goes from people who are fully able, so they're not using devices, they're not reducing their activities, they're not reporting difficulty or help. A new group that we've called successful accommodation. These are people who are using devices, but also have not reduced their activities and are not reporting difficulty or assistance. That group that is reducing activities, but they're still not reporting any difficulty or help. Individuals who have difficulty doing activities by themselves, even some of them when using devices and ways to try to accommodate. And then finally, the group who are receiving assistance, receiving help from others. So if we look at this spectrum, we see that almost a third of older people are fully able, and another large group, 25%, have successfully accommodated. You see a small percentage, 6%, who've reduced activities, 18% reporting difficulty, and then 21% receiving help. So it's kind of interesting to look at this same spectrum across residential settings. These are weighted numbers in the millions. As you would expect, most of the fully able individuals are concentrated in traditional community environments. But if we look at the successful accommodation group, which is about 25% overall, the percentages there in each of those settings are really fairly similar. I think they're, they range. They're in the lower in the 20%, low 20% range. Not a huge amount of difference across those. Now, about half of people in the residential care supportive environments are receiving help, as you would expect, and that proportion is substantially higher than in the traditional community settings. This shows you that same spectrum for individual mobility and self-care activities, and what I would just point out here is that it appears that successful accommodation is much more common for bathing and toileting across these different activities. We also do see differences by age, race, and gender. So this is 5-year age groups, and this suggests that successful accommodation kind of peaks in that 75 to 84-year age range. But even, among the very oldest people, 90 plus, you still have, a substantial percentage who are successfully accommodating for functional change. Women are more likely to receive assistance than men, but they also are more likely to successfully accommodate than men. And whites are much more likely to successfully accommodate than Black or Hispanic individuals. And interestingly, the fully able percentages don't vary as dramatically as you might think across those groups. So here, just looking at the left side of the slide, I think it's on your left, we can look at the spectrum against the participation restriction measure. So this is the percent with any participation restriction. And you can see, as you would expect, that there's a stair step, but actually the difference between those who are fully able and those who successfully accommodate is pretty small. The blue line at the top is a well-being score that we construct out of some of our other measures that are, indicators of people's subjective well-being and happiness and so on. And that too suggests that, it doesn't really dip down until you get to the activity reduction group. There's not a difference between those who are fully able and those who successfully accommodate. So some summary points around the spectrum I just was talking about. So we're able to use the NHATS framework and measures to put together a new approach to thinking about disability that allows us to see how limitations are being accommodated by older people, which is new information. We're able to distinguish different groups between those who are receiving help and those who are fully able, and they really represent sort of different stories in that those who successfully accommodate in many ways look like the fully able groups, whereas those who are reducing activities and having difficulty may be at risk for further decline, but also, thinking about the spectrum this way, I think gives us some opportunities to better target where we might want to focus intervention. So there are many unanswered questions about this. Who does successfully accommodate, and why, and what kind of transitions occur across these different levels, and are there groups or activities that should be targeted if we want to move more people into the successful accommodation group. So there are many other features of NHATS that I don't have time to talk about to help us advance our understanding of disability trends and trajectories. We will have 8 years of annual follow-up under our current funding, and for the that's the 2011 cohort, and the 2015 cohort we'll have 4 years. There's a broad range of content I haven't talked about in terms of economic well-being, interfamily exchanges, early life measures, and so on. There are opportunities, as I've said to many of you today, for modules from external investigators to be incorporated into a round of NHATS, and you see listed here some of the ones that we have conducted, and this is a great way to keep the content fresh, and also bring in additional investigators to the study. There's some important ancillary components. There's the National Study of Caregiving that we conduct. These are interviews with caregivers. And there's a last month of life interview that's conducted if one of our participants dies. And we're doing linkages, as I mentioned before, to Medicare data. So this goes back to my very first slide. I hope that I've been somewhat convincing in terms of helping to push the case for disability as an important public health issue in late life, and one that I think provides numerous opportunities for public health interventions, and has significant implications for the quality of life and well-being of older people and their families. So I'm very pleased to have had the opportunity to talk to you today, and I'm happy to answer questions. Thanks.
We have time for 5 minutes of questions.
Okay. Yes.
The microphone.
Thank you. I think my name is Rich Saints. Nice to meet you. You are convincing that function and disability are what's important. But in our health system, what I see is that there are measures of what the number of your blood pressure is, and the doctor needs to address that, and the number of the hemoglobin A1C, and the cholesterol number, and one could even argue that hypercholesterolemia and hypertension are not really even diseases, they're simply risk factors. So where does, should this be addressed in the health system, or should it be addressed best somewhere else? Where's the priority piece for public health?
Yeah, so that's a very good question, a hard question. I mean, I think that I think the health system is going to be pushed more in the direction of these kinds of issues. I mean, if you think about, patient-centered care, that suggests part of what you have to pay attention to is what matters to the person. And if what matters to the person is they can't, walk down the block to, get to their favorite stores, that's what they want attention paid to. So that's one piece of it, I think. I also think that, and I'm sure there are people here that know a lot more about the Affordable Care Act than I do. I mean, I think for example, if hospitals have to worry about someone not being readmitted within a particular period of time, and part of making that happen has to do with what kind of supports are in that person's home and what the environment is that person is living in. Again, I think that's kind of going to push attention to these kinds of issues that, they may be paying attention for reasons that have to do with not bringing the person back into the hospital, but it still, relates to these issues of disability. Yeah.
Hold on, there's a microphone coming.
You gave a collection of implementation of the very controversial Affordable Care Act. Not, of course, all these subjects are on Medicare.
Right.
But can you do analyses? Do you have a sample size so that you can look at those states that, let's say, have more enthusiastically embraced the Affordable Care Act and the amount of disability in their older population compared to those states that have been less enthusiastic and not participating fully in the Affordable?
So not really, because the design of the study is one that allows us to produce national estimates, but we cannot produce state level estimates. So you really cannot compare people, in one state versus another state. I mean, I do think that because we're dealing with the Medicare population, they are not as affected. I mean, even in terms of Medicaid eligibility, because Medicaid eligibility for people 65 and older is really driven by income, and so it's really not part of the picture of whether a state decides to do Medicaid expansion or not. But we really, that's really not an issue we can address. Yes.
So in light of your comments, I was wondering, how's that Baltimore football team doing?
Next question. Yes, George. Oh.
I'm wondering if you could comment on sort of the household level issue of disability when you've got multiple people over 65 living together in this sort of tenuous equilibrium. And I wonder if that's represented in the sample at all.
Well, in a pretty limited way. So we really, our sample consists of individuals, so we don't, for example, bring in couples. We know who's in the household. We also know if there is a spouse. We ask about whether the spouse needs assistance, needs help with activity, daily living. We ask if the spouse is not in the household, are they in a nursing home or residential care? So we have limited information, but probably not the ability to kind of say, you've got two people here who are in need. So.
Yeah, we have, plus, I said you don't do couples.
Right.
I was kind of struck with the absence of Sept. And we discussed some people put down some favorite activities.
True, they do. Yeah.
And usually Pfizer, they would say that number one disability is it fails to direct that function.
Yeah.
Is Sept playing that whole day?
Well, we don't ask. It's not an area that we have content, on. So we really can't answer the question. I mean, there certainly are people who focus on that.
Yeah,
and
there are.
There's a lot of
It seemed to be a
work.
perfect study.
Right,
Someone else
right.
to come in and do.
Right, right. Well, yeah, so we have a small. I think I'll leave it at that. I think we'll leave that, we'll leave it at that.
There's a question about.
Is there a disconnect between individuals' continuing sense of well-being and the actual I thought I saw well-being stay up even as
Right, well, I mean, that's a good question. It's really a research question, I think, because, there are people who even with severe disability may still express, high levels of well-being. I mean, so we have the data to to look at that issue. What I was showing, so that is a score that we constructed out of a lot of well-being measures, you're right. I mean, from what it doesn't maybe dip down as much as you might expect, even for those people who had high levels of participation restrictions. But I was kind of focusing more on the other end, and the fact that the successful accommodators are doing as well as the fully able. But that's really an interesting research question, I think.
Ask the question. Yeah, go ahead.
Your data is very, very interesting. It suggests that a lot of the accommodations and assistance that people are receiving are not specifically medical, but covered by Medicare, and which was constructed at a time when perhaps these kinds of accommodations weren't as necessary. So I was wondering if you collected any data on the source of payment.
Yeah, good question. So we actually do ask when people tell us they've added various accommodations. We ask about costs. So we do have some. I don't know that. I mean, that's students. That's that's not been mined. It's certainly an important issue. And I was going to say something else related to that. But in the caregiving study as well, we ask caregivers about whether they have whether they spent their own money to get devices, do home modification, things in that same realm. So I do think that's in terms of looking at costs that aren't, as you said, aren't part of what Medicare has traditionally covered. That's an interesting area.
I have a related question actually about funding. This is really a question that you got a question about, given your results, what you think the impact has on financial policy, funding policy at Medicare. Would you say that what you have learned bodes better for the trend towards community-based care and funding towards that, or incentives? Because I know that has been the trend, or more towards residential care. If there's any impact at all that you're seeing?
Well, I'm not sure anything I showed today directly, answers that question. I mean, I think, what you're referring to is what has been happening in Medicaid, which is for the lower income, part of the population, and the fact that there has been a real concerted effort to try to move money out of nursing home environments and into community care. And I think that's a trend that continues. I mean, I think people who focus on that area point out that happens much more for the younger disabled population than the older population. And the other thing, to keep in mind is that most Medicaid does not cover much in the way of non-nursing home residential care, so assisted living and things like that. It's really not in either the Medicare or the Medicaid world, except, I don't know if there are states that do more of that, but it's so I don't think my data addressed it. I probably have gone into areas where I'm maybe speaking out of turn, but yeah, so.